Okay, in the interest of time, I will get us started. Thank you for joining us here today, and welcome back to day 3 of the MMRC Symposium. My name's Beth Murray Davis. I'm the Scientific Director of the McMaster Midwifery Research Center, and I'm really glad you're able to join us today. We are in webinar format on Zoom, so just a few little bits of housekeeping that you're there at the bottom of your Zoom bar, there is a Q&A box. And if you have any questions for our panelists or have any concerns, you can type a response there. We will be saving some time for questions at the end. And it is possible for you to raise your hand and put your microphone on at that time when invited by us to do so. So hopefully if you have some questions, we can do it in that format. Or again, you can type your questions. We do ask that otherwise you hold all of your questions until the presenters have finished, and then we'll be happy to take your questions at that time. So before we begin, I wanted to offer a land acknowledgement. It's a very windy day here in Hamilton, and I think it is in other places in Ontario. And I am in Hamilton, close to the McMaster campus, which is situated on the traditional territories that have been they've long been a meeting place and the home of the Haudenosaunee and Anishinaabe nations. And their presence has been foundational to the history and culture of this land and is recognized in the agreements like the Dish with One Spoon Wampum Belt and the Haldimand Treaty Territory. And as a settler, I'd like to acknowledge that my role is a guest on this land and that I am learning how to share in the responsibilities with the caretakers of this land to ensure the sustenance and well-being of all. But I do offer this with the spirit and intent that we go beyond just land acknowledgements and that we need to think about how we actively listen, learn, and unlearn the narratives that have been shaping our understanding of this land and the people here. And, action and learning are key steps towards truth and reconciliation and the ongoing process of decolonization. And I think it's important that we remember that decolonization cannot be a metaphor. It has to be something that we act upon. And with Red Dress Day this week, it's a good reminder. The red dress is a symbol of all the lives that have been lost to violence and an important reminder of the ongoing issues of violence and discrimination faced by Indigenous communities across so-called Turtle Island. So we must continue to advocate for justice and healing and action to end these systemic issues. So if you haven't already had a chance to explore places where you can take action, there's lots of great resources related to Red Dress Day. So I encourage you to go and look at those today. I am really grateful for everyone who is here spending some time with us today. And I think we have a really exciting panel discussion lined up for today. Our symposium has different content every day, and we try to mix things up and have different formats. So if you haven't had a chance to already, check out our full program. We do record our sessions, and then with a little bit of time for us to put things together, we'll be sharing more information after the week on our website. So check that out at mmrc.mcmaster.ca for recordings and details about the days that lie ahead. Tomorrow is actually our last symposium day. We've decided to keep it to 4 days this week. So we've got a great lineup tomorrow if you want to check out the calendar. And you can come back and join us using the same Zoom link that you used today. So as I alluded to, we have a fantastic panel today. We've had a lot of success with our symposium in previous years, offering panel discussions, and particularly hosting panel discussions related to some of the nuances and learnings and implementation lessons from the expanded models of care sites that have been popping up across Ontario. And today we're doing that again, but with a particular lens looking at collaboration and really wanting to dive in more deeply around collaborative models of care and the lessons that can be learned about that from some of the sites that have been working at that and exploring that over the last few years. So let me introduce you to our panelists today. We have Lauren, Harrison, Lisa, Liz, Nana, Mila, and Suzanne. And I'm going to ask each of them now to briefly introduce themselves and to share a little, brief blurb about who they are and where they come from. I would encourage you to go to our website to look for the full bios of all of these spectacular people and to hear more about the work that they're doing over on the website. But maybe we will go in the order that you appear on this lovely poster. So let's start with Lauren in the top corner there.
Sure. Thanks so much, Beth. I am a registered midwife who works in the T.I.M.E program, which is a collaborative model based out of London Health Sciences Centre in London, Ontario. I'm also a researcher with the Schulich School of Medicine and Dentistry at Western.
Thanks, Lauren. Okay, Harrison.
Hi, everybody. So I'm Harrison Banner. I'm a maternal fetal medicine specialist at Western University and at London Health Sciences. I'm also one of the co-creators and the physician lead for the T.I.M.E program that we're here to talk about today. I wear a few hats at the medical school as well in terms of education and running a fellowship program. So I'm very much involved in training the next generation of interprofessional care providers.
Great, thanks, Harrison. Lisa.
I'm Anishinaabe registered midwife from Wacomico unceded territory on Manitoulin, and I live and work in Thunder Bay at Delico Anishinaabe Care. And I was a part of establishing the midwifery practice here and work with Nana and Suzanne.
Beautiful, thank you. Mila.
Hi, thanks for having me. My name is Mila Smithy. So I, like Harrison, am a maternal fetal medicine specialist. So I do high-risk obstetrics. And I am very intimately involved with the Oracle program at the Ottawa Hospital where I work. And that's what I'm here to talk about today.
Thank you. Liz.
Hi, I'm Liz. I'm joining you from Halifax, which is in McMuggy. I'm also here to talk to you about Oracle, where I worked for 3 years. Now I'm a policy analyst. My views today will not represent the views of my current employer.
Thanks, Liz. Nana.
Hi, I'm Nana Jima. I'm an obstetrician gynecologist in Thunder Bay, and I have a specialization in addiction medicine. I am part of the Delico midwifery care team along with Lisa and Suzanne.
Wonderful. And Suzanne.
Hi, my name is Suzanne Fitzpatrick. I'm one of the first Indigenous midwives with Delico Anishinaabe Family Care. I'm from Fort William First Nation, where I live and work out of. I'm also a registered nurse for 27 years, so I'm really happy to be here today.
Great, excellent. I can't wait to have this conversation. So maybe what we'll do is we'll stop sharing our slides and we will launch into our panel discussion. And the way that it's going to go, we have kind of a first round of questions where the 3 sites who are here today will have about 10 minutes to kind of do a bit of an overview and to answer a few specific questions. When that's done, we'll do a second round where we're going to have kind of a more collaborative conversation, building off what each other has kind of mentioned in the first portion. And then we will have a third round, which will be our time for questions from the audience. So that's our plan, and I will try to time keep and keep us on track. So for our first kind of round of questions, I'm going to start with Lauren and Harrison, and I'm going to ask that you describe the model where you work, and you can include things like the type of care and services you provide, how you organize your team, who you serve, any insights like that, and maybe tell us as well about the benefits of having an interprofessional team looking after the people that you're serving in your program.
Sounds great. Thanks so much, Beth. I'm going to get started. We launched the T.I.M.E program coming up on 2 years ago here in London, and it's a hospital-based expanded midwifery care model that's funded through the Ministry of Health's midwifery program. For anyone who's not familiar with those EMCMs, just briefly, they are ministry-funded programs that are sort of have the mandate to support midwives to work in slightly different models and different ways than they might otherwise work in the traditional midwifery practice group model. Some of the goals are to sort of, help improve the health system, reduce barriers, not duplicate services, and maybe reach different populations than what we typically reach through midwifery care. That is also part of the goal for our T.I.M.E program. So it's a model of collaborative care that's was set up between the Division of Maternal Fetal Medicine and the Department of Midwifery here in London. The program was designed to provide this really comprehensive prenatal and postpartum care to this, specific segment of the high-risk MFM patient population who had sort of met a set of different kind of specific criteria based on some additional risk factors, and just those who might be disproportionately impacted by the social determinants of health. And the goal is, to really kind of maximize the scope of practice of midwives and really support patient-centered care to kind of bridge gaps and increase the efficacy and even the sustainability of the care that's being provided in London. Our foundational goal of the program was really to improve sort of a series of health outcomes for this population by just reducing barriers to access that kind of like nice, seamless, holistic care that midwives are really known for, especially in terms of bridging the prenatal through postpartum care, and add that layer into the existing MFM care that's provided to this high-risk population. The type of care that the midwives are providing, we do not take over as MRP antenatally. These people are under MFM care for a reason, and so they will be having their babies with the MFM team. However, we add this sort of additional layer of a lot of antepartum education and more kind of holistic supports, social supports throughout the antenatal period in conjunction with MFM. And then we pick up care in the postpartum right after they've given birth, and then provide 6 weeks of community-based postpartum care for both the birthing person and newborn.
Yeah, so just to expand basically on what Lauren said, so we as an MFM group, there are 6 of us at our site. We see a wide range of patients, and we have a very large catchment, though we're based in London. Specifically for the T.I.M.E program, we really wanted to expand the care that we are providing to a subset of our population. So people who are geographically based in London, mostly for logistic purposes, but really targeting people who are traditionally underserved by the medical system or who have difficulty accessing care. So we have a lot of patients with like low socioeconomic status, people who are underhoused, newcomers to Canada who have trouble accessing care. We have a lot of patients with significant mental health concerns who require a lot more time and care than our system is currently built to provide for them. And then within our MFM program as well, we have a lot of families dealing with difficult diagnoses, a lot of fetal anomalies, or babies who may have a limited life or a palliative course afterwards, who can really benefit from the extra time and attention, both antenatally and postpartum. So the goal was really to build on a program that we already have and really leverage the expertise that the midwives provide, that they could add to the program for a segment of the population that may well have wanted midwifery care but would be unable to access it because of the risk factors that bring them to MFM. In terms of the benefits of having an interprofessional team like this, I mean, there are a million benefits, but this really allows us to leverage the individual skills of different care providers. We do have different skill sets, different training. And so, you know, I noticed from a very early point in my training that the care that we provided to our patients was very good, comprehensive medical care, but it left a lot to be desired in terms of some of the interpersonal support that the midwifery model provides, both antenatally in terms of just doing the normal things of getting people prepared for labor and birth and parenting, and then particularly postpartum. I mean, it's no secret that the obstetrical model really falls short when it comes to providing postpartum care to our patients. They have a lot of trouble accessing care when they need it, when they do have complications. People sit in emergency departments for really unbelievable amounts of time. It's hard to get them seen in a timely way, and they don't have nearly the support from a transition to parenthood, to breastfeeding, to access for mental health support and concerns. So really those were the big goals of bringing the midwives into the team and making it a truly collaborative model that allows us all to work to the top of our scope and actually probably beyond our scope in many ways. And really to not compromise on the care that our patients are receiving.
And I would say an additional benefit that we've noticed is just that having a care provider who's very traditionally community-based, such as midwives, but actually giving them a role within the hospital and having them maintain all that skill set for community-based care means that there's now a bridge for our clientele and our patients. Whereas typically we know from a lot of great research that there's not a lot of bridging between outpatient antenatal care to inpatient intrapartum and postpartum care to community-based care. There's always things that are missed. There's rarely ever any continuity between those services. And so what we brought was sort of this thread that could connect everybody through the prenatal, care all the way through to the postpartum unit and into the home. So there's a nimbleness, I think, and a competency that midwives have in providing home-based care that just not a lot of other professions are, used to or able or set up to do. And so we can really meet people where they are. Community-based care and care close to home is so, so important and so critical for people who face sort of a larger number of barriers to accessing care. And so being able to it's almost like we're bringing a little bit of the access to MFM to people in their homes. So when we see them and we're concerned about a postpartum wound infection, they don't have to just sit there and wonder and go to emerge. We can just text the MFM, their MFM, and say, hey, this is what we're thinking. What would you do? Or can you call in this script, or whatever the case may be? So we can do a lot of sort of like coordination of care that just otherwise wouldn't happen. I had like a tricky UTI page the other day, and so I was just able to directly text their care provider and sort of get some assistance on that. Otherwise, this person would have been calling, waiting a week for an appointment. Like there's all sorts of barriers to why that becomes challenging. I think that sometimes this type of care doesn't feel like it's necessarily important or necessary, I guess, for a large number of the population. But people with like really, really complex social determinants of health just need so much more coordination and careful planning, especially when we're talking about those who do not speak the primary language in most hospitals. Even just a basic, make an appointment to get your IUD put in is really, 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 really challenging, and ultimately where so many gaps happen and so many failures in the system happen. So our job is really like, we now have someone who can, prescribe and insert an IUD, and we have them here in the community, and we can just like really bring them together so much easier than if they were just left to navigate the system on their own. I would also just add briefly that I think we all are fairly well aware that the general sort of midwifery caseload population sort of services a really select segment of the population. It tends to be a little bit of a higher SES, low risk segment of the population. But there's a whole group of people who don't access midwifery care because it's really just challenging, to know like at -3 weeks pregnancy that you want to get in on a list with a practice. They fill up very quickly. You need to know about them in the first place. And so there's this whole segment of the population that rarely accesses midwifery care. And by creating this program, we kind of get to the group of patients that would have an MFM and need an MFM, and then bring midwifery care right to them. We do our appointments at the same time. So it's really sort of removing all those barriers to accessing a really specific group of the population.
That's great. Thank you for that overview. And Lauren, did you say how many midwives are part of the T.I.M.E program?
I didn't, but we now have technically 3.0 FTEs in the T.I.M.E program. And there are 4 of us sharing that. And yes, and then 6 MFMs.
And it sounds like you have kind of a criteria in mind for which people in the MFM clinic are good kind of candidates to be part of the T.I.M.E program. So is that like a formal checklist, or how do you decide? Or is it as their course of care, proceeds, then sometimes you say, wow, this person would really benefit from the T.I.M.E program?
Yeah, it's formal and informal, but sorry, Harrison, you can go ahead. You're the one making the referrals. So.
I was just going to say, so any of the MFMs can refer into the program or bring patients into the program. We do have criteria. And so generally what will happen is if patients meet that criteria, or if their MFM identifies that they would benefit, they'll talk to the patient. I've yet to have somebody say no when they're offered additional midwifery care and support. And then we register them in the program, and the midwife meets with them at the next appointment to introduce the program more broadly.
And
so logistically, it's getting harder because as the program's getting more popular, people are actually requesting to be referred to MFM to be put in this program, which is a whole separate issue. But it's almost like many successful programs, getting hard to then decide who can't access the program because we are limited in terms of our resources.
right, yeah, that's an interesting point that now it's so successful, other people want to be part of it, which is great to hear. And how do the midwifery appointments work? Are they add on to the MFM appointments? Is it that you try to, you know, when someone comes for their appointment, you know, everybody sees them that needs to see them that day?
Yeah, that's correct. So we just try to catch them when they're already there. Sometimes logistically, that means we see them before MFM or right after or at the same time. So it's a little bit wild because there's always more than one MFM per day, and can't say they run on time in any way, shape, or form. So, you know, kind of coordinating that is a bit of a runaround. But yeah, we're also part of, like, many people are seeing multiple services in a day when they come. And so if there's any care planning meetings, like we're a part of that as well. And yeah.
That's great. Thank you. Okay, we better move to our next site so we can continue to hear the stories from other places. I still have lots of questions about time, though, that I want to get into, so maybe we'll save that for the end. But Lisa, Nana, and Suzanne, can you describe for us the model or program where you work? And again, thinking about the types of services you offer, how you organize your team approach, who you serve, and then if you can also tell us a little bit about how collaboration has allowed you to better meet the needs of the people in your community, that would be really great.
I'll get started. I wanted to share just a brief history because like the collaboration definitely improves care for patients, but I also wanted to highlight how it improves care for providers and for growing programs. So I've been a midwife since 2007, and when I first came to Thunder Bay in 2010, I wanted to start working here because I knew that there was a large population of Indigenous people in the city, and from knowing midwives, there was a very low portion of midwifery care provided to the population. So when I started working here, I was doing a similar model to what I'm doing as far as having outreach midwifery, where I was finding clients who wouldn't normally be seen by the midwives, and then doing primarily home visits and doing just pretty much working on my own doing care. But I was recently widowed and had 2 young kids, and that wasn't able to work for me. Like I really enjoyed what I was doing and really wanted to bring midwifery care to Indigenous people, but not able to do that. Ultimately, I ended up working with Dr. Juma as a research assistant after I did a master's of public health. And we worked together when I worked on some of her projects looking at substance use in pregnancy in Northwestern Ontario and developing care pathways to improve care. So we were just like this perfect couple of providers, me wanting to work in the community and Nana wanting to improve care for her patients. So we were able to be one of the first Indigenous midwifery practices funded in Ontario, and we've been working since 2007, where we're now a team of 3 midwives, and Suzanne's going to share how that happened. And so people come into our care in different ways. A lot of them come directly to us either from self-referral from previous patients or as referrers from other providers. And then for those people, we do a little bit of prenatal care unless they need to be referred to Nana earlier. And then a lot of our patients also come from Nana, where people are referred to her for obstetric care. And if she identifies that they could use the benefit from our care, then we become involved as well. So there's no standard way people are seen. Some people are seen just at the maternity center where Dr. Juma does clinic. A lot of people are seen in our office, but I would say the majority of our visits are actually done in a community as home visits or a site wherever is appropriate for that person, either in shelters or in detention centers or even just like Tim Hortons or wherever is appropriate for them. There's a very high portion of our clients are substance involved or have major socioeconomic factors that limit their ability to access care other ways. We don't do interpretum care, we do prenatal care only, and then in hospital, all of our patients are under Dr. Jima, or sometimes we have other delivering physicians involved. And then postpartum, mom is under obstetrics, and then baby is usually under the family doctors who do care for babies in hospital. And then after discharge, we take over for mom and baby again and do at least 6 weeks of postpartum care. Sometimes we hang on to people longer if they're needing extra supports. We are able to do immunizations for babies that don't have a care provider, but we're also quite fortunate to be able to roster patients onto some of the family doctors and nurse practitioners at Delico. So that's briefly what we do. I was practicing on my own for about 2 years, and then we had funding to have another midwife, but there was no Indigenous midwives available to work with us. So I want Suzanne just to share about her experiences, a bit of her journey and how collaboration helped that move along.
Okay, so I'll actually start a little bit about the agency that we work for. We work for Delico Anishinaabe Family Care. They started in around 1986 as a child welfare for Indigenous communities, involving 13 First communities around Robinson Superior. Eventually, they went through health transfer with 7 First Nation communities in the Robinson Superior. Then later on, adding mental health, addictions medicine, community health, home and community care. So I started back in 2008 with Delico as a community health nurse. So from there, I wore different hats. I was a Healthy Babies, Healthy Children's nurse, and then moved over to Integrated Services, which was basically a wraparound program for families who were struggling, and for those that were just borderline, possibly kids going into care. So it's just wrapping around, ensuring that families remain together. During that time, I definitely had a lot of nurses to preceptor and midwives as well. So it really built my passion towards being a midwife. Going back to school was just wasn't in the cards in time where I was. Being a mother of 2, grandkids being born, so it's just a lot of helping out in community with family. So back in 2019, Delico was looking for another Indigenous midwife, and that position remained open for a long time. And I was looking at it and thought, well, you know what? I do a lot of this in my job right now. So I took the chance and I applied for the position. So very unique for Delico because it was never done. So from there, we got the approval to go ahead for the apprenticeship. So that was like 2 years of being mentored by Lisa. Like we worked side by side for those 2 years. I also was mentored by Nana Juma, who was fantastic, attending clinics, putting things together. I also did some courses through Mohawk College, the obstetrical nursing program, just to give me that background and knowledge of perinatal health. So in combination of all of that, was able to get through the 2 years and complete the apprenticeship and then be acknowledged through Delico First Nations as their first Indigenous midwife. So it was a very, very good journey. Really enjoyed the work. And I think just a lot of my own practice over the 27 years of being a nurse, life experience. My work has always been in Indigenous communities, so definitely an understanding of, the challenges and the barriers for our people on a day-to-day basis. the impact of colonialism, intergenerational trauma. So that definitely helped with this role as Indigenous midwife. Working with Delico, it definitely very unique because we have a family health team, we have dietitians, pharmacists, we have addiction treatment. So it's very valuable in the work that we do, and our resources are there.
All right, so I will pick up after them. I have Post-it notes. If I'm looking down, it's because I don't want to miss anything because I am so overly enthusiastic about this program and I don't want to talk on forever as well. So in terms of my practice, before the midwifery practice started, I was always seeing very socially high-risk patients, a lot of patients who are homeless, marginally housed, substance involved, a lot of patients who are living with intimate partner violence, incarceration. A lot of my patients came from Indigenous communities. A lot were also non-Indigenous. I see a lot of patients from remote First Nations who have to fly into Thunder Bay. So it's a very challenging population that I work with, and I absolutely love working with them. And I would try, before working with the midwifery practice, to provide as much social support as I could with a social worker who's at the maternity center, which is a hospital-based maternity care program in Thunder Bay. But both of us are sort of limited in terms of what we can do because she also had to support the other 7 obstetrician gynecologists who are there and provide services for the community as a whole. And I really could see that we needed to do more for the patients that I was working with. Particularly for the Indigenous patients that I work with, I think it was a little bit easier for me working with them than other obstetricians in the community because just of who I am as a person, like I'm a Black immigrant woman. I don't think that they associated a lot of the stereotypes and negative associations with colonization and all the ramifications of that with me because I was a non-white, non-male physician. They oftentimes didn't even see me as a physician, and that allowed me to develop trust with them and trust-based relationships. But definitely there was still that gap and you know, a need for more to be done that I just couldn't do. And so when I was working with Lisa in a research capacity, I was kind of nudging her along, like, you need to get back into practice. You can do this. We can work together. We can have different ways that we can make this work. And when that program came up from the ministry, we jumped on applying for it, and I supported her to put that application through. And, you know, we really talked about like could the program be housed and how could that be of benefit to the community. And since that time, it's been absolutely fantastic. You know, originally working with Lisa, developing the program, we practice in a very similar way. Despite Lisa being a midwife and me being an obstetrician, I don't think there's any difference in the way that we practice, which is really important because it really does provide that seamless care. Obviously, like others have said, we have different skills, and I can provide that medical support because a lot of the patients we see are also very medically complicated, and I can provide that addiction support because I did that additional training. And Lisa and now Suzanne and Amy provide a lot of that care in the community, the pregnancy care. And because we practice in the same way, if there is a truly low risk patient, I like to meet them early on in pregnancy just so that I can, you know, have that meeting, get to know them. But then I'm happy for the midwives to care for those patients, and then I'll see them again at the end of the pregnancy or at any time that they need. I think that it's also really wonderful for the patients that we see that their practice can see patients for more than the 6 weeks postpartum. And we see some patients continuously from one pregnancy to the next without interruption. But I think that's part of the cultural aspect of the care, in that Indigenous midwives or women who practice as Indigenous midwives would care for women as a whole person, not looking at them in pregnancy, out of pregnancy. It's something that's a continuum. And I find that in working with the Indigenous midwives, that has been the biggest impact to my practice is just really changing the focus of the care from like a medical care, which they need sometimes and I can provide, but really caring for them as people. Having that cultural aspect to the care has been phenomenal and goes such a long way in terms of improving care overall, not just, you know, how they feel or the medical care, but really the overall care has like it's just been night and day for a lot of my patients. So I'd say that is the biggest change in terms of this collaboration, and I'm forever grateful for it.
Thank you. Wow, this is amazing. The passion that you all bring to your work is so fantastic. I'm hearing that already, and lots of strategies that I've heard from both sites already around flexibility and being, you know, creative in how you meet the needs of your community and how you work together, and obviously a strong commitment to that collaboration, which is so wonderful to see. I'm going to turn now to our last site to let you share the overview about the Oracle program. Tell us a little bit about the services you provide, you know, how you organize your team, who you serve, and what are the ways in which you think having an interprofessional team has enabled you to meet the needs of unique populations in your community.
Do you want to kick it off, Mila, or do you want me to go? Okay. Okay, I'll start. Just to carry on the tradition of the midwife goes first and then the OB comes behind and fixes all of our stuff, just like in real life. No, I'm joking. So I'm going to talk a little bit about Oracle, and I don't want to start talking about Oracle without saying the name Amy McGee, because it's really her program. It was her brainchild. And Amy is the person who organized all of this in Ottawa, starting in, I don't know, 2016 or something like that. So it's been going for a while. And Amy's a midwife, like me, but better. And she's also a social worker. And she was doing outreach work kind of informally for a long time. And then it got formalized into Oracle. And then she brought me on, and I followed her around like a puppy for 3 years, trying to learn stuff and trying to pretend to be her, which is what I'm doing here with you today. So Oracle is an outreach collaborative perinatal care program. And we work with, and I'm quite fussy about language. So we do not serve, we work with families at risk of child apprehension. And that's quite a diverse group, because there's lots of reasons why you could be at risk of having your child taken by the family regulation system. That could be because you are using substances, which a lot of our clients are. Could be because you are embroiled with the justice system, which lots of our clients are. Could be because you yourself were removed from your parents' care as a child. Could be because you are living with the impacts of racism and colonization. Could be because you are living with trauma and violence. Like, there's a really wide range of things that put you at risk for those interactions with family regulation. So we see a really broad range of people in a broad range of life circumstances. Oracle provides comprehensive perinatal care, so prenatal care, intrapartum care, and postpartum care. And we also provide wraparound sexual and reproductive health services outside of pregnancy. So stuff like STBBI screening and testing, contraceptive counseling, all of that kind of stuff. And the goal is firstly to like help people be well and help keep families together, which is sort of everyone's goal that does this work. And a lot of that has been touched on by the other panelists, so I won't dwell on that piece too much. But I think a really important piece of the work that we do that speaks to the interprofessional piece is we also help clients feel okay about the healthcare system. Because our clients are people who are likely to have ongoing need for encounters with the healthcare system, and also people who, because they are sensible and smart, have a lot of mistrust of the healthcare system due to previous experiences that they've had personally or that people they know have had, or institutions in general. One of the major barriers to seeking and receiving healthcare is that feeling that a healthcare institution is a place that's not for them. And one of the cool things about being able to work in the hospital and in the community is being able to, over the course of the time we spend with people, show them that the healthcare system actually can be a place for them. So we get referrals from all kinds of places, community agencies. We get a lot of self-referrals. You know, we get a text that says, oh, I'm a friend of thus and such who just had her baby with you. Can I come and have my baby with you? And often when we're first meeting people, they feel really resistant to care in the hospital. They feel a little ambivalent about going to see our OBs who are just so wonderful. And then we get to sort of talk them up and be like, no, you're really going to love Dr. Smithies. She's so nice and she's going to give you like the greatest care and you're going to love going into the hospital. Don't worry about it. I hope you love just going into concrete buildings. It's going to be great. But getting to the point where over the course of pregnancy, and as we all know, like pregnancy is a time when a lot of change is often possible for people. They feel really motivated to explore new ways of doing things. It's a time of transition. So we get to sort of show them that the hospital actually can be a place for them where care is centered around them, where they can feel safe and where they can start thinking through their goals and meeting their goals. And that's really important in that pregnancy and for the health of the pregnancy and the health of the parent and the health of the baby and all of that stuff. But it's also really important for when they're not pregnant anymore, because maybe the next time that they need medical care for a different reason, the hospital is like no longer a super scary place. It's a place where they know they've been well treated and well received and like really loved and cared for and supported. So I think that's a sort of an occult piece of the work that we do. So we're trying to improve people's health and support them to improve their health, but we're also trying to support them to improve their relationship with an institution and demystify an institution. And that's really cool. In terms of the logistics, one of the great things about Oracle is it really allows people to play to their strengths. So as has been mentioned by other people, midwives tend to have a lot of flexibility in how we work, and that's sort of what we're used to. Our MFM colleagues have to see 3 billion people a day, and then they have to read ultrasounds all night. So they don't really have time to be tootling off to the jail or to the shelter, but we can do that. We can meet people at home if there's barriers to them coming in, or if they're not really feeling ready to go into the hospital yet. Like we have a lot of flexibility in the location of where we provide care. And of course, we have a lot of flexibility in our scope, right? OBs don't typically do a lot of baby stuff after babies are born. And that is a piece that we do. And it's a really important piece that we do. At the same time, because we're working with people who typically are quite medically complicated, there is a lot of clinical knowledge that's way and well outside of the scope of what midwives do. And the OBs do a beautiful job, obviously, of managing that piece of it and of making that knowledge accessible to our clients too. And that's a really big part of helping people feel comfortable within that institution, is going to see the OBs in the hospital and feeling respected in the way that things are explained to them, feeling respected with the knowledge that they gain and with the way that their decisions are supported, and really feeling collaborated with and worked with. And that's super important. From my perspective as a midwife, I always felt like the OBs were kind of like the midwives to the midwives, because sometimes I would encounter a clinical situation that I feel very unsure about, and I would text Yvonne or Laura or Mila for the brief time that we overlapped, and I'd be like, hey, this is super weird and I don't know what to do. And they'd be like, don't worry, you're doing great. Everything's wonderful. Anyways, I'm going to write a prescription for your client. So that was really lovely. So we started off structurally as the midwives working within a midwifery practice group, which is sort of like the bog standard way that midwives work in Ontario, in an independent practice group, and just kind of like in a little bubble within the practice group, and then going through the usual, like the regular referral process for MFM, and just having conversations with the administrators there so that they would be directed to the appropriate place. And when the program started, it was really just a couple of the MFMs who were working with Oracle clients, but now I think it's everybody who's like really gotten on board and been super supportive. And on the midwifery side, Oracle has just transitioned, and I will not be able to speak to this at all because it happened after I left, but Oracle has just transitioned from that MPG model into an EMCM, kind of like what Laura and Harrison are doing. So that's been a big and really interesting transition. But I have to defer to you, Mila, because you know how things are now, and I don't, because I disappeared, vanished into the ether.
So I cannot speak to that at all. So Liz did a fantastic job of giving an overview of Oracle. And I'm glad you kind of started by saying Amy McGee's name, because that had been my intention as well. So this very much is the creation of an incredibly subspecialized and devoted midwife, Amy McGee, who I think the crux of the Oracle program is truly the outreach portion of it, which Liz very thoroughly went over. But the midwives are able to go and do their assessments and provide their care anywhere, and I think that is invaluable to these pregnant people who really, one of the main barriers, as Liz alluded to, is difficulty in accessing care in more conventional settings. And as everyone has kind of acknowledged, a lot of the pregnant people who are in our care are very much in need of medical care, which I think in large part is provided in hospitals for good reason. And Oracle allows for this connection or bridge between the hospital and literally anywhere. And it truly now has been a program embraced by the entire MFM team at my site. So there are 5 of us who work at the Civic site in Ottawa, and we are all involved because it would be very challenging, certainly in our model of care, to have a designated MFM, because the care has to be quite flexible. So how we do this is every Monday morning there's a meeting with all of the MFMs and then all of the Oracle midwives. So currently there are 2. And we run through any ongoing issues, anticipated problems, kind of upcoming deliveries or anticipated deliveries, or just strategizing how to provide care to people who need it but who aren't coming, so that everyone is aware of what's going on, so that should something happen relatively acutely or unexpectedly, or on a day that's just atypical, that it will be something that can be managed by anyone. And then we're also quite flexible, not just in day, but in manner and mode of how the care is provided. So, I mean, ideally, there will be a clinic appointment, ideally on a planned day, but sometimes that doesn't happen. And it's, I think, quite innovative, the strategies that we've been able to come up with, and sometimes very much in the moment, to how to best provide care. So I've done appointments on speakerphone in a car, and it's been the midwife's phone because the pregnant person doesn't have one, and it's worked very well. Or I've had people come in for their ultrasounds and leave because they don't want to wait, which is understandable, because I think it's been mentioned a couple of times already that the waits can be long, and then get a phone call after with me to review the findings and kind of suggest next steps. So it's very flexible, both in terms of the location of the care, but also the manner of delivery of the care. And the beauty of the program, I think, is the collaboration. So not just the collaboration between the MFMs and the midwives, but the collaboration with the midwives and their clients. And I think someone mentioned this earlier, but the care being not just kind of medical care, but caring for them as people. And we currently have a woman in labor who does not have a home or a safe place to stay, who is currently accompanied by the midwife, who is her support person. She's getting food and a shower, and has been able to sleep a couple nights in the hospital while deciding if she wants to be induced. And it's been wonderful to actually be able to see this kind of preamble to what will no doubt be a stressful time in her life, and kind of a ability to transition into comfort with the medical system and with what's going to happen next, with the continuity provided by her midwife, who's been along with her kind of intermittently, not by choice but by circumstance, throughout the pregnancy. And I don't know what will happen next, and almost certainly the mother and baby will be separated. But I think that she's had this opportunity to have, you know, I hope a relatively positive experience in the medical system and get care for her non-obstetric issues that very much need care. And we've been able to kind of galvanize the medical system and coordinate these, what would I think typically be quite, you know, long wait time referrals to subspecialists, all of which she will benefit from, who are coming to the birth unit to see her, is quite remarkable. And this is one example, and there are countless examples that I can think of, kind of occurring nonstop. So again, that Amy McGee conceived of this and formalized it and has funded it and has kept it going and has found many extremely subspecialized, extremely devoted midwives to join her in it, because it's absolutely tireless work that they're doing, is remarkable, and I think really should be lauded. And I'm actually quite heartened to see that it's occurring in various forms kind of around the country. I find it just wonderful.
Thank you so much. And I love the shout out to Amy McGee. And I think it really speaks to the need for champions, you know, to lead this work, right? People who have that vision and can keep moving it forward when you run into so many obstacles and roadblocks and people that are not on board with the plan. Which segues really nicely into our next round of questions. So we'll keep these ones shorter, maybe 2 to 3 minutes per site. But if you can share from your experience what you think are key ingredients for successful collaboration and any strategies that you've had to use to deal with, you know, barriers or challenges that have come up. And we'll start, with Lauren and Harrison.
Sure. So maybe I'll start by talking about the kind of key ingredients for our program. So I think the biggest thing is that we've had very, very early stakeholder buy-in on both sides. I mean, Lauren and I have been talking about a better way of providing care for pregnant people since I was a resident, which is a few years ago now. And as we've kind of grown together in both of our careers, we've really tried to envision what that would look like within our existing healthcare system. And so trying to take that like big scale dream into something we could actually do has been a challenge. But from the point of view of this program, we are very lucky that we have colleagues that really bought in very early on, people who already, from my colleagues in MFM and Lauren's colleagues in Midwifery, have a deep respect for what their counterparts do, the shortcomings or limitations of our own ability to serve people, and how we could really come together and build a program that does even better than what we can currently provide. And that kind of buy-in and open conversation has allowed us to build a program, but also to constantly reevaluate what we're doing and say, like, what's working, what's not working, what can we do better? So we're constantly reevaluating our needs, reevaluating how we're providing care, and reevaluating how we work with each other.
And then in terms of some of the challenges, I think one of the big ones with working with a different profession is that there's a degree of vulnerability in letting someone into the care of your clients and patients. And I think it's because we're quite aware, and the MFMs were quite aware of, again, like our limitations and our training and our scope. And so, you know, being let into the patient population in the way that the MFMs provide care meant that they were vulnerable in us seeing sort of the areas that they were maybe falling short in, and having to kind of lay that bare and say, like, what can you do to help? And that does require a vulnerability, but it also requires like a lot of insight to see that you have shortcomings in the care that you provide, which is really hard because everyone's very dedicated and passionate about what they do. But it involves that insight, and then that kind of growth mindset and willingness to say, but how could we kind of come together to be like greater than the sum of our parts? And that synergy that happens when you take people with slightly different skill sets and can kind of adapt to that And I think the midwives have a vulnerability as well in terms of like, I've not cared for medically complex people before. And so there's a lot of knowledge gaps. I do not have the training and the expertise and the fellowships that, the MFMs have. And so there was a vulnerability there of just, not knowing a lot and having to sort of admit to my like limitations in my knowledge. And I think that's a challenge, but I think I can say that we've really managed it quite well within our group. And I think a lot of that just came down to some really basic respect that you really have to feel that sort of in your bones in order to be able to collaborate successfully like this.
Thanks, Lauren. Yeah, I think the vulnerability is a really interesting point and speaks to that need for respect and trust within that collaborative relationship so that people can come and be vulnerable and share those moments and reflections. So thanks for getting that discussion started. Nana, Lisa, and Suzanne, what would you like to add in terms of ingredients for successful collaboration and ways that you've had to address challenges and barriers?
If I can start with one thing that's more a systemic issue, and that's just Indigenous midwifery and people's understanding of what that is in the medical model, and how Indigenous midwives can be incorporated into care. I think that's something that was relatively easy for Lisa when she started because she was a registered midwife, but maybe more of a challenge for Suzanne as an Indigenous midwife because it isn't really understood what that is, and it doesn't really fall under the traditional hospital classifications for care providers within a hospital, and understanding what that looks like. So in one of my other hats that I hold in an academic position at the hospital, I've really been trying to work through that with the hospital so that Suzanne can provide care in the hospital and people understand what her role is. I mean, she does anyway, as in a supportive fashion, but so that she gets a badge and is recognized as an Indigenous midwife, because I think that's something that's really, really important. So that's something that's ongoing, but it's a challenge we didn't experience with Lisa because she was a registered midwife and there's a pathway for that within a hospital system. But as an Indigenous midwife, there isn't. And so we've had to come up with creative ways to sort of make that happen, and that's still work in progress. The other issue was because she's an Indigenous midwife and I'm not an expert on this, so please jump in and correct me if I'm wrong at any point. The legislation around Indigenous midwifery means they can practice in the community where they have been accepted as an Indigenous midwife. And because the practice is at Dalico Anishinaabe Family Care, which is for Robinson Superior Treaty, that's been something that's incredibly important because the midwifery group here can provide care across Robinson Superior Treaty, and they don't just see patients in Thunder Bay, they actually travel to communities, and Suzanne can work in the hospital in Thunder Bay and in other hospitals in the region because it's on the traditional territory. And so just developing that understanding amongst healthcare providers, administrators, I think is work that we need to do, we are doing, but it has definitely been a challenge to incorporating that care within the traditional hospital structure.
I would agree with Lauren and Harrison's comments about like the respect and trust and having that communication. We also have a weekly meeting where we review all of our clients with Nana, and she brings new clients to us. But I think one of the other aspects to mention is the problem solving and how we come and look at an issue or a challenge from different perspectives, and how none of us are afraid to just do what needs to be done. Because we're really like all of these programs are in Ontario groundbreaking. Like nobody had a framework for how to build an Indigenous midwifery practice and how an obstetrician and midwife should work together. So we just figured things out as we went along and really based it on what the needs of the patients are and how are we going to be able to meet those needs, and what resources do we need. Recognizing that we, even as a team, we can't do everything. So we were able to get a social worker that works directly with our clients and just relying on other programs within Dalico. So I think that's a big part of the collaboration for our team. Is it's not just our team. We outsource and bring in other stakeholders and just do whatever needs to be done to improve the care of the pregnant person and her baby.
So yeah, I mean, the circle of care for our clients and families. So I mean, we're just one piece of that circle of care, and definitely making the connections, not just with our agency. We have a lot of resources, but for those that are living or.
Oh, I think you went on mute by accident, Suzanne.
Just looking for those resources to help women and their families to move forward and support them the best way we can. And definitely working with a team, especially as a new Indigenous midwife, definitely a big learning curve. So important for those connections and communication.
Thank you. Yeah, lots of lessons learned, which is fantastic. And the issue of credentials for Indigenous midwives and the lack of pathway for how to bring them into the hospital system is definitely an issue that I think other communities have been faced with. I know Lauren has been doing some work in London on that as well. So it might be worth a separate conversation about that at some point to share resources because it's such important work. Mila and Liz, what are some key ingredients for successful collaboration and again, strategies that you've used to deal with challenges or barriers?
Well, I think I'll echo what everybody else has said about trust and respect. And I really liked what you said, Lauren, about having that insight to recognize that it goes both ways. You know, your collaborator has to trust you just as much as you have to trust them. If I have a shared client with Mila who is medically complex, Mila has to trust that when I go and see this person, I'm going to do an appropriate assessment and I'm not going to miss anything, and I'm going to do things that are going to be conducive to the work that Mila is going to do later. You know, sometimes it's hard to know the difference between I wouldn't do it like that and you did it wrong. And building trust really means being able to know the difference and to know where somebody doing something differently can still be going toward the same shared goal. And I think that's the key, is everybody on the team has to have the same vision for what we're all supposed to be trying to do. If I were to pick one thing to be the real secret sauce, though, it's you have to enjoy it. Like, you really have to like the work. You have to enjoy your clients. You have to enjoy your colleagues. Like, you have to be able to just really like it. And I mean, I'm speaking for Oracle, like, it's clear we all really like it. Like, I love it. I miss it. Amy keeps trying to get me to come back. I told her she can move the program to Halifax. I'll be there tomorrow. But you like, truly, like, these can be deeply enjoyable experiences as a provider. And I think if you're missing that, like, really deep enjoyment, like true appreciation for the clients, like letting the clients see that you enjoy them and appreciate them, letting your colleagues see that you enjoy them and appreciate them, finding pleasure in working together, because the work can be really hard and the work sometimes can be really sad. And if you don't have that piece of like truly finding lots of joy in the work that you do, it's very hard to do it in community with other people, because the small frustrations and the small pieces of friction and trying to find each other in a way that's going to work can get overwhelming if you don't have that piece to hold it all together.
Mila, any lessons or learnings that you want to share about collaboration?
I mean, the benefit of going last is that most has been addressed already, but I just like honestly to echo what everyone is saying. And I think to make it more broad, like, these are obviously incredibly innovative, subspecialized programs that we're discussing today. But I think one of the benefits of them is that they've sort of self-selected, as Liz has said, very devoted, interested, engaged providers to be a part of them. But I think the perhaps more insidious benefit of them is that it's allowing the hospital, and I think other providers, including other midwives and other obstetricians or other obstetric care providers, to see that collaboration is not only possible, but quite positive. And that it can be, expanded to less disenfranchised populations and less medically complicated situations, and that there is, benefit to discussing shared patients collaboratively, and that there is something to be learned from everyone. So I think that that is an important piece to have, and that I view it as kind of a slow, gradual, but I'm hoping kind of ongoing culture change, at least at my hospital, towards collaborative care, both formally and informally. So I think that's a kind of a key lesson to be learned, not just from us within the Oracle program, but kind of as an institution at the Ottawa Hospital.
Yeah, that's such a great point, is how we can learn from these exemplar sites for, collaboration throughout, the perinatal care realm, that it doesn't just need to be these subspecialties where we see that level of collaboration, that this would benefit everyone. And I really enjoyed what you had to say, Liz, about the joy in the work. And it makes me think of, first of all, you all come across as very passionate about what you're doing, which is fantastic. But it makes me think about, some of the conversations we're having about sustainability and burnout and issues within the midwifery profession, and that the joy in work is one of those positive things that's been found to keep people in the profession. And so if we can find ways for people to do, this work that brings you so much joy, it might keep a lot of us in the work for longer. So that's really a positive thought as well. Okay, so I've really enjoyed hearing more about each of these sites, and I think we've had a really rich discussion. We actually are done a little bit earlier than I was hoping, which means we'll have more time for questions from the audience, which is fantastic. So a reminder that you can put your questions in a written form in the Q&A box, and I will bring them aloud to the panel and people can take turns answering them. You can also raise your hand if you have something that you'd like to share, and we can allow you to turn your mic on. There is already, and this has been present in the chat for a long time, and I wanted to just flag it, a lovely note from Carol Cucci expressing thanks and gratitude to this panel of superstars, and that you're really a group of people we can look to for solutions for Indigenous life givers and their families, and that you're living the embodiment of Joyce's principles. So I think that was a lovely note from Carol. So thanks, Carol, for sharing that. Wendy St. Laurent Coots has also mentioned that there's lots of questions, nothing specific at this time, but she has to leave, and she's just really grateful for all the amazing work that everyone's done. So lots of gratitude and appreciation for what you've shared today. I don't know if there are other questions from people here today, specifics that you'd like to dive into. How does it work? Or, what does the day in the clinic look like, if you want to get into the granular level, or if you want to hear more about the big picture or systems issues. I think anything is fair game. So feel free to raise your hand if you'd like to ask a question. And panelists may have things you want to respond to from the other panelists that you've heard. So we can certainly widen that as well. So yeah, Lauren, go ahead.
Something that Harrison and I chatted a bit about in our preparation for this was just some of the challenges around like hospital integration. And it sounds like others have touched a little bit on that as well. And I think that hospitals being very inertial systems and very resistant to change and sort of more likely to find barriers as opposed to sort of solutions. I think that's a maybe challenging reality that happens in any instance where you're trying to create a novel or innovative program that is different from what is currently offered. And from the sounds of the way other people have described their program, that's the goal of all of these programs. And it's amazing to see that sort of repetition of like, but then we face this barrier and then we face that barrier, largely just sort of historic hospital barriers. And we have our same pile of inertial sort of change resistant issues that we dealt with as well. But there's a part of me that feels like, as Mila mentioned, that the more that this is modeled and successful, it likely means that it's more likely that another hospital would be willing to try it if there's sort of a successful model or example of how it could work, or even just somebody laying out like, this is how we do it. This is how you get over this barrier and that barrier. So that's just a reality. And also the fact that leadership within the hospital will have sort of maybe competing goals or just different goals or visions than you may have as well for that program. And so it's, I guess sticking with the dream, vision, benefits that you sort of really believe you might be able to bring with this. And and being able to navigate the system that way.
Yeah, and hearing you speak about those issues, Lauren, makes me think of like the need for almost a shared group of the people doing this work across the province or across the country, a time to bring people together to share resources and share lessons learned and to continue to, kind of help pave the way in other communities where people may be passionate about this but aren't sure where to start, which also segues into our next question in the Q&A box. So Elizabeth Brandeis has asked, have there been funding barriers to your programs? And how did you make your case for accessing funding? And what advice would you have for others who are trying to launch similar programs? Does anybody want to tackle that? The money.
Oh, I'll talk about that. I spent a lot of time writing proposals. Yes, to your question, Elizabeth. Hi, Elizabeth. Yes, there's been funding barriers, so many funding barriers. It's hard to get cash from the government. Like the government only has so much money and they need to spend it in so many places and they hate to spend it. God bless them. But actually, interestingly, the hospital has been one of our biggest assets in overcoming funding barriers because I think Oracle has aligned with a lot of larger scale goals that the Ottawa hospitals identified. And I mean, hospitals are institutions, they're corporate bodies, and so they have the same corporate goals that any other corporation has. And if you happen to catch them in a moment of alignment, they can really throw a lot of institutional weight behind you, which holds a lot of sway with other large institutions. Hospitals are kind of like people. All corporations are people. They have an inertia, as you mentioned, Lauren, that comes from their history and their sort of corporate memory and experience, just like people do, right? Like we tend to keep going in the direction that we started. And the more we reinforce things with our same experiences, the more we want to keep going that way. And it can be very hard to turn around. But sometimes something happens in your life and you have this amazing moment where change is really possible. And if we can act on that in that moment, like when somebody comes to me and says, I really think I'm ready to decrease my substance use in this pregnancy, it's like, okay, great, let's do that right now. So sometimes, you'll have a hospital or any institution that'll put in their board report, we're really looking to leverage the benefits of collaboration. We're trying to save money by optimizing scope. We're trying to do any of these things. Excuse my cough. And then you're like, yes, okay, great. This is our moment. If you can put yourself in alignment with the direction that they're already going, the inertia works for you and not against you. And that's really something that we have found in the past because the hospital has been very generous with things like letters of support when we've been asking for funding, because the benefits that our program brings are really aligned with the kind of benefits that they want to see. Where I think you run into problems where the benefits that you bring are benefits, but they're not benefits that are aligned with the benefits that the institution wants to see. And that's where we've run into problems with the ministries before, right? Where we are unquestionably bringing benefits, but it's not the kind of benefits that fit their metrics. And it's not the kind of benefits that they're looking to see. And again, we're seeing a big shift there, right? Like workforce management at the provincial level is a really different conversation now than it was 5 years ago, because the HHR, the health human resources landscape is really different now than it used to be. So I think in situations where someone is facing a funding barrier, that would be my advice, is look for a space where you would be the path of least resistance and make sure that decision makers see you in that light.
Yeah, aligning yourself with the strategic goals of the organizations and seizing those moments when they come your way, right? That when there's a funding window, you got to go for it, even when you feel like you're not ready.
Yeah, and with Oracle, we had some success in getting more cash out of the ministry, where we had to do it in a specific and a strategic way. the funding issue is a real problem for Oracle when we were in MPG, because midwives in Ontario bill on a course of care basis. And in order to qualify for a course of care, you have to be with somebody for 12 weeks or you have to attend their birth or both. But when you're providing episodic care, often that's just not possible, right? If you're seeing somebody who is only in town transiently, you might not get them for 12 weeks. And when the OB is MRP, it might just not, it's not really feasible to attend every birth when you have a very large client list and very few midwives, but also it's just not an efficient use of resources for the midwife to come and sort of be the doula at the birth in order to be able to bill for that client. And for all of the episodic care we were doing, like wraparound SRH care, like that's just not billable under the current funding model. So Amy was initially able to negotiate a separate stream of funding on a sort of an hourly basis, but it was always inadequate to what we actually needed. And we were also able to negotiate some funding that was built into the model that was for our clients, right? We called it basic needs funding, right? Stuff like taxi chits and Tim Hortons gift cards for people and grocery cards and that kind of stuff, so that we could actually address, and prescriptions, so that we could actually address the social determinants of health that were contributing to ill health where it was found. And also we were able to actually help people access the care that would help them get better. It's not much good giving somebody a prescription for labetalol if they can't pay for it. So we had success in all of those places, but sometimes we would come to them and say, like, look, our clients have really identified a need for longer postpartum support. Will you fund us to add that into the program? And we would hear, no, there's plenty of other organizations that provide that same thing. The benefit to our clients of having that trusting relationship with us continue and being able to get that sort of early baby care from us, providers who they knew, not to have that rupture and have to build trust with a whole other provider, was obvious to us. But that benefit didn't align with the benefits that the ministry was trying to see in terms of optimizing care and making it more efficient across the province. So sometimes you just get lucky and sometimes you don't.
Thanks, Liz. And there's another follow-on funding question, and I open again to the whole panel. Have you tried funding avenues that are different, like NGOs, international, private innovation, or corporations funds that might process this as part of kind of social responsibilities funding, thinking outside of the public funding streams? Anybody have experience looking in those kinds of different avenues for funding?
I don't want to speak twice in a row, but we did look into that.
Yeah.
So when we've had funding, I won't say shortfalls, but when we've been in positions of austerity before, yes, we explored it all. We explored even stuff like social enterprise models where, you know, we could leverage some of the resources that we had at our disposal to do something like build a social enterprise for other parts of the community that would then subsidize the work that we were doing with our clients. And stuff that other communities have done, right? Like baby banks or play groups, which have a fee associated for those who can pay, and that subsidizes it for people who can't pay. But it's logistically very complex. There's a not insubstantial amount of financial risk associated with it. Like you have to incorporate your organization as a nonprofit and to pursue some streams, and in order to incorporate as a nonprofit, you have to meet certain criteria for how your revenue is organized, which aren't compatible with being medical corporation. And so, like, it gets so complicated. There are so many structural barriers to having money go where it is the most needed. Capitalism, as it turns out, is actually quite complicated. Unfortunately, it's what we've got to work with. So I think, again, my advice for somebody who's trying to navigate that would be to look at what's already established and look at what's there. Like if you work with a hospital, that hospital has a hospital foundation. So for example, look at what is an eligible expense under that hospital foundation. Look at how, excuse me, look at how you can subdivide the expenses that your program has, and see if you can kind of split them up according to whether they align with another organization's mandate, and see if you can get different subsidies for different line items. Like, just be creative, I would say.
Thanks, Liz. Lauren, and then Nana.
Yeah, and I think to Elizabeth's question about funding, I mean, it appears that all of us are funded through the EMCM or IMP type of funding offered through in collaboration between the ministry and the AOM. So I think just stating that that funding program and that concept to fund these types of models alone is one of the main reasons that these programs exist and have been sustainable. And so, prior to that, I know there was like slightly smaller ways that people could access working through, caseload variables and things like that. But I think this really formalizes it. So, my dream would be obviously that funding continues to grow and be accessible for these programs. But the other piece is, as Liz mentioned, like in most of these cases, the funding for the obstetricians is not the issue because they can just bill for the care that they provide. I mean, I know it's not perfect either. I know that there's, billing codes that don't accommodate like the length of time that you are spending with patients and things like that. But it's really like the funding for the midwives who can't provide episodic care. And so have to rely on something like a salary model through an EMCM funding. So it's really largely a midwifery funding model issue in terms of just how we bill and how we're paid. I think any sort of changes or improvements there would mean that some of these barriers just wouldn't exist, that as they don't necessarily for our obstetrical colleagues.
Yeah, great additions there, Lauren. Thank you. And Nana?
Yeah, so I just wanted to add just maybe a different perspective to the conversation around funding. And so I think it's great to get funding through an EMCM program and to put in those applications and put in applications other places. And it's completely reasonable to look to outside organizations. But I think what underlies all of it and successful applications is that you've demonstrated that you've worked together as a team. And that you have worked in this area and that you have an idea for a program that's sustainable. And so that's where I think some of these smaller pools of money from foundations or things like that can be really helpful, just in terms of funding maybe a smaller piece of work to show that can then demonstrate that you can work collaboratively with other care providers and provide some type of service that is of benefit to the community or the group that you're looking to work with. Because we're all talking about sort of similar types of patients and individuals that we're working with, but that might be very different for another community or another location. And so I think like foundation funding, things like that can be really helpful just to sort of get things going, do different projects, give you different ways to collaborate and work together and develop that foundation so that when applications arise for funding, you can put something in and have the background to show like, yes, we've worked together. Yes, this is important for the community. And like give us the money, we can get off the ground running. So I think that's where it can be really, really helpful, or even like a needs assessment if you haven't been able to do that formally in your community, to then provide the background to say like, yeah, listen, this is needed in our community. This would be a benefit. Providers think so, patients think so, and how can we make this move forward?
Yeah, some great points. And I think the needs assessment is such a great way to start for anyone who's thinking about doing something like this. It's a great way to make the case and to demonstrate that this is necessary in your community. And my own personal plug for the funding piece too is that I think we need to continue to look at funding for the evaluation and the clinical outcomes that are happening in all these places. You all have tons of data about the people you've been working with, what their outcomes are, what that looks like, and the impact that it's had. And I think we've been kind of missing that piece. And we've had some conversations in other places about how important it is to embed researchers within your unique settings as well, that it's not always appropriate for an outside researcher to come and to, collect data and do their thing. It's really about people being within your systems who know how it works and all the nuances, who could help with that research piece. So some research funding would be amazing to add to that wish list. We have one more question in the chat that I will read out, and then I think we probably will wrap up after that. So the last question is there involvement in your health regions or broader systemic work of clinical planning and implementation from a provincial lens to expand these types of interprofessional models in both acute and primary care sites throughout the province? So I don't know if anyone feels like they can speak to that, but the potential for expanding this type of work, this interprofessional magic that you've all demonstrated for us?
I think you'd have to ask the province.
There are,
We're all busy doing the work.
yeah, exactly. Yeah, we need the bigger picture stakeholder kind of perspective to take that on. And there are conversations happening about the primary care reform and collaboration within that. So, you know, maybe each of you can be part of that, bringing a voice to that group as well. Lauren?
I mean, I think that question is excellent in that it speaks to sort of the amount of repetitive work that has to happen in every community to sort of create these models that probably, if we had good evaluation research on the models, would just sort of be like a given that this is an excellent way to provide care, and then so let's figure out a way to do it. So I think probably an answer to that question would be that there has to be evaluation work done on these programs to show that there's probably hopefully better health outcomes, savings to the systems in other ways. So if, our goal is to, reduce ED visits and readmissions, for example, then there has to be some sort of economic analysis to the savings there, and then how that could be applied to fund these programs and et cetera. Definitely not my area of expertise, but I think that sort of collaboration with people who are skilled in that area of research could mean that you have the outcomes, they're published, and they can be, more broadly, I guess, implemented at a provincial level and part of some of the strategy.
Yeah, that's great. Thanks, Lauren. Another just expressing of gratitude in our Q&A box. People have been really inspired by what you've had to say today. And it's probably a good note to end on. And so I am very grateful to all of our panelists who have shared such amazing insights into the programs and places where they work. And it is incredibly inspiring to hear the stories and to know that this work is happening across the province. So I'm really touched by what I've heard here today, and it sounds like other people have been as well. So thank you to all of you for sharing that with us. And this, as I said, is our kind of it's our second last day. Tomorrow will be the last day of our symposium. So I would welcome you to join us again. We will be here at noon Eastern Standard Time until 1:30 again. And tomorrow we are showcasing a couple of MMRC researchers. So we have Jenny Brunton and Abigail Corbin, who will be presenting on implementing group postnatal care at the Oak Valley Health AMU. And then our final speaker will be Karen Lawford, talking about bringing our babies from the stars, returning to Indigenous midwifery, which will be a fantastic note to end on and to round out the week together. So we would love to see you back here tomorrow. We will share a poll now so you can share some feedback with us about the panel today. And don't forget that we hope this will be shared and posted on our website. And we also have a newly launched podcast, and I'm wondering if we should post this as a podcast episode so that people could listen to the audio when they're driving and out doing home visits and all the things that midwives get up to. So we'll work with our panelists to have that conversation, and maybe we'll share it in that way as well. So thanks everyone for joining today, and have a good rest of your day, and we hope to see you back here tomorrow at noon.